All right, thank you. I'm excited to be here this morning. I'm Katie Baca-Motes. I work with Dr. Topol and Dr. Turkamani here at Scripps Research. By show of hands, how many of you guys have heard about the All of Us research program? Okay, all right, so I don't have to give much of an update. The All of Us research program, for those of you who haven't heard about it, it's an ambitious, historic, huge now effort going on across the country. It's led by the National Institutes of Health. And what we're doing is inviting 1 million or more people to start sharing health data, so biosample data, electronic health records, self-reported survey data, and we're hoping to follow these folks for 10 or more years and contribute to a research database that's going to be open to scientists all over the world. I'm going to start by one of our intro videos. It's done by our friends up at Wondrous up in LA to give you a little bit of a flavor. All right, I'm doing technical difficulties already this morning. It's going to work, though. Got good vibes.
The vision behind this whole idea is longitudinal. It is collecting information about people over time. Many of our clinical trials don't have enough people in them for us to say with statistical certainty whether the drug has worked just as well for men as it has for women. We live with the laws of averages. And so there are lots of ways in which we as docs can make a huge difference in a more participatory model for clinical research by having 1 million people who have signed up to be part of the clinical research process. One big thing that comes when you have larger studies is you have statistical power to get an answer. With 1 million people, you might suddenly be able to say, might this be something new that we haven't recognized? So I think we will learn things that we haven't dared guess at. We're going to make it lots easier to get answers quicker for important questions. Something new comes along, say a new infection. We have, our current one is Zika. Well, you can then pull samples that were put in the freezer 3 years ago and say, was this actually already present? It's going to really change the face of clinical research. My real hope for the precision medicine cohort is it similarly builds a cadre of people who are loyal to the study and proud of participating and eager to continue this donation of information about themselves into the future.
So this video was shot, I don't know, back in 2016, which is when Scripps initially got involved. So all of the grants were given back in July 6th of 2016, I think, and we've spent just hours and hours of meetings and setting up structure and task forces and governance, trying to get this thing off the ground. Like I said, it's a big, ambitious initiative. But that's not where it all started. So it started 15 years ago when Francis Collins started making the case to Congress and the NIH about why we would need something like this here in the United States. So this was at the end of the Human Genome Project, where he started to make the case for really what it was going to take beyond what the science was doing now to get this rigorous and unbiased conclusion about the causes of diseases. And it will need and require a population that we track over time. And he made a case for doing this here in the United States. And in the way that only really, really smart people can, he basically laid it out in a page and a half, right? And this box right here is the blueprint. And I only came across this paper actually a couple of weeks ago, and I stared at it for the longest time because it is really humbling after 2.5 years of meetings and ongoing conversations and conference calls to be able to look back at this blueprint that was done 15 years ago, where it spelled out basically 80%, 90%, 95% or something of what we have to do. So he talks about what it would require in terms of number of participants. And so he talked about several hundred thousands. We're now aiming for 1 million. He speaks to the need for oversampling populations here in the United States that have been traditionally underrepresented in biomedical research. So that's racial and ethnic minorities, sexual and gender minorities, people who live in rural areas, lower socioeconomic status, lower educational attainment. He speaks to the biological specimens that are going to be needed. He speaks to the highly sophisticated data management systems that we need. He speaks to the type of consent that we're going to need to continue to get information from people over time, and more importantly, to return information back to our individual participants. So it's great to kind of see, 15 years in the making and where this all started. And he often talked at the time after the Human Genome Project and what it enabled. He came back to the story time and time again about, somebody who's had a few too many drinks, maybe lost his keys, is somewhere in the park, and the police officer comes up to him and says, "Hey, why do you keep looking in this one spot?" And the response was, "Well, that's where the light is," right? So we were at the time really limited to finding these medical discoveries that were underneath the lamppost. And what the Human Genome Project and the HapMap project did is it allowed us to turn on more and more lampposts. So lots of people got busy doing the science, many of the people in this room. And we really started, the number of associations here, the number of studies, the number of papers that came out of this era, it was just rapid growth. And it was pretty amazing. But it was very clear to everybody that that wasn't the end state, right? We weren't going to uncover the mysteries of what made people, stay healthy, why people got sick by just, the genomic information alone. We were going to have to add in these things like real capture of in-health data over time as the technology grew and grew. We were going to have to track measurements over time. We were going to have to look at environment. We were going to have to look at electronic health records. So we're excited about that as the All of Us research program. We're wondering what is it that we can light up next by taking all of these things, putting them together into a database that's going to be open to everybody. So you heard great stories from Sonia and Eric yesterday morning as they started out our patients, and how hard it is to access information, how hard it is to start to get into research. Let's say you're interested in something, 80% of the research papers are behind a paywall. That's annoying, right? As a regular person, you can't even read the type of research that's out there, much less go in and start to build a database to get to the questions that you have. So really what this is we're going to take all of this information, we're going to take the genetic information, we're going to pull electronic health records, we're going to get self-reported health data from surveys over time, and what we're building is the All of Us Research Hub. It's going to have the data for you, it's going to have the infrastructure already built, and you're going to be able to go in and really just speed up medical research. So instead of going out, building your own cohort, getting the infrastructure, figuring out how you're going to capture all of these data types, and it's tough. You go through the IRB, you go through everything, you go through your clinical trials. Believe me, I've got tons of our team here in the room today. It's a lift, and in hopes for this to make it easier for people to figure out how you create your cohort with just a click of a button. And again, all of this is private, it's secure, there's levels of access that are all being worked out, but this is the end goal. So where are we? Like I mentioned, we started this in 2016, and we launched less than a year ago. So May 6, 2018, we had big parties all across the country in 7 cities. So we were in New York, we were in Chicago, Detroit, Birmingham, Nashville, Kansas City, Pascal, Washington, all over the country. I might have missed one. And we partnered with community partners, and we pulled in our participants, and we started inviting people to join, because that's really what the All of Us research program is we can't do it without 1 million or more people of diverse background who are willing to contribute their most personal data over 10 or more years. So we got people excited. The NIH was at all of these events. We had mariachi bands, we had dancing, we had all sorts of fun things that went on, and trying to get people excited about the program. So we are now, along with our participants, we have over 1,000 people working on the project with hundreds of organizations, some which work with us at the Participant Center here at Scripps, including companies like Walgreens, Blue Cross Blue Shield, WebMD, companies that have never been involved in medical research before. So our team has done a great job of kind of helping them through that process, which is eye-opening for some of them. And we have great community partnerships all across the country because this really is a grassroots effort. We don't want any of our communities to be left behind. So the word's got to be out there. We've got to start reaching all of these different communities. And so it's organizations like National Alliance for Hispanic Health, the YMCA, San Francisco General Hospital Fund, and others. They've done a great job at spreading the word. Our most important asset is probably our participants as partners. So one of the good things about our program is it's not just, checking a box like, sure, we treat our participants as partners. We actually truly invite them in as partners. These are some of our national advisory board, some of whom are our Scripps virtual advisory team, Gus, Lottie, and others. And this is a picture of them sitting around with the steering committee out in Bethesda. We fly them all out there, and they're there from the ground up, really building the program. And they have amazing insights, just like at these conferences. The best part, for me at least, is when the patients come and the patient stories, because they bring such a different lens and a different story and different considerations. And we found that when we go out to our participants, they often have great insights that nobody else in the room does. So we're excited to work with them. We have over 150,000 people right now, a little higher than that. These slides were due a couple of days ago. So we're improving every single day. These are active participants who have gone in, consented in the program, and started to contribute some sort of data. We have over 100,000 biosamples over at the Mayo Clinic, and then physical measurements and things that are going into the Data Research Center, which is over at Vanderbilt. We have this number yesterday, I just found out, went over 500,000. So we have over 500,000 surveys, online surveys that people have started to contribute either through an app or through a web-based module. We have over 55,000 electronic health records. And per Dr. Collins last night on a WebEx, we are now considered the largest, most diverse research project that the NIH has ever been involved in. So that was a great accomplishment for us. We're excited about that. Thank you. Thank you. And one of the things that we're really excited about is this number right here. 77% of our participants right now come from these traditionally underrepresented and biomedical research backgrounds. So about 50% come from the racial and ethnic minority categories. Others are rural populations, and the others that I mentioned. So we're hoping to engage people over time. And this is going to be the reason that we can come back and really hopefully address health disparities for all of us, right? So what's ahead? This is where I get involved. So I'm not in genomics, I'm not in AI, but Eric and Ali work with me because I'm really into the human behavior aspect of it. So I've worked at places like Disney Research and things like that, right? How do we engage participants over time? How do we truly understand human behavior in a way that we can bring this full circle and truly alter the way that healthcare and medicine is done? So a 10 or plus year engagement, I mean, that's any company's dream, right? You want all of your population, all of your consumers to engage with your product for 10 or more years. It's an ambitious goal on top of already the ambitious goals of being the largest, most diverse, most everything, right? Building this amazing infrastructure. We've got to do this too, which is practically impossible for any consumer-facing company. So we need to do this with a deeper understanding about how people interact with health research, how they interact with their providers, and how they interact with what is becoming more and more individualized data returned back to them over time. And this is happening, right? So we are returning information. People have more and more information at their fingertips about their individual health. You've got sleep data that people can do. You've got your ECG on your wrist. You can track everything with these wearable devices, sensors. You have access to your electronic health records now. As it's been mentioned a couple of times in this conference, you've got polygenic risk scores and things coming out from companies like 23andMe. You've got our very own polygenic risk score here from Ali. And people are freaking out, right? We're like not ready for that as a medical community. What is happening? How are people going to understand these things? So much genetic testing, so few people to explain it to you. What do these things mean? Should we just halt and say, no, we're not going to give back this individualized data? That would be one way to do it, right? And it makes sense, right? If we take a look at how information is transferred, this is an old article. It's several years ago. Wired magazine did this great write-up where they talked about how basic information, like your basic blood work, is given back. So this is just the first of 4 pages of your basic blood work, probably faxed over to your doctor and maybe given back to you. And if we give information back to people like that, it's no wonder we should be scared, right? Who's going to understand this? Who's even going to bother to read it? The same goes for the heart disease test. Same for the prostate test. These are not information in a way that people can easily digest and capture. So what this article did, it was really great. They connected with a couple of medical professionals, 3 amazing designers, and they said, well, what does it look like when we actually design this for real human beings to take something of interest back to you? And they did a nice design. So they said, first stab at it, we're going to redesign this in a way that actually makes sense for people. So they did all 3 for us. And those are the things I think that we need to get to as a All of Us research program, but more than that, as we start to think about how health information is communicated back to individuals. And it's not just the way we communicate back to individuals, it's the channels in which we do so. So there was this great article last spring of looking at our communities and looking at the health disparities amongst communities, and this in particular was Black men, and I believe it was originally done in Dallas, but taking a look as if we check their blood pressure, if we provide medications in a space that is social and trusted, like a barber shop, what does that do to help decrease health disparities? And so there was some nice articles, or nice research studies funded by the NIH and looking at this. But it wasn't just, if you read the article, it's not like, oh yeah, we're going to give you your blood pressure in a barbershop and it's all going to magically, improve outcomes. It didn't happen. They ran the first study and it failed, basically. The outcomes weren't improved. But then the researcher had also looked at other clinical trials where they were looking at pharmacist-led interventions. And he decided to combine the 2 in the second round of studies. So they took the barbershop, they did their initial blood pressure, they got their results, and then they separated them out into 2 groups. One was instructed to go get treatment and do follow-up from their physician. The other was this pharmacist-based intervention group. And that's the group that did it. That's the group where we saw the outcomes actually improve. So more and more research around how do we do this, what channels, how do we communicate, and who does that communication back to individuals, participants, and patients. Another great example, this was an article a couple of weeks ago from Cass Sunstein in Bloomberg op-ed, but he discusses an interesting paper. There's this this thing, and it was part of the Affordable Care Act, and now the current administration is pushing for it too, to put calorie counts on all menus, right? This makes sense, right? I mean, we want everybody to make healthier choices, and so if we make sure that, places like the Cheesecake Factory or, Chili's are putting, the calorie counts next to, the Bloomin' Onion or whatever. I'm mixing up all of my different chain restaurants, but if we see how many calories are going to be there, then maybe we'll make better choices, and we might opt for the salad or the chicken wrap or something over the cheeseburger. Huge initiative, people change their menus. I mean, this is a costly endeavor as a nation to do this. And the results were meh, right? They were mixed. So they took a look and tried to see, are people actually changing their eating habits? Are they ordering healthier foods? And it's very, very mixed. There's a couple of studies that see it, and for a couple of subsets of the population, people are making different choices. But for most of them, they aren't. But this study done by Stephen Dallas, Peter Ubel, and Peggy Liu came out a couple of weeks ago, and they did an interesting one where instead of, like most restaurants, you put the food and then you put the calorie count next to it. on the right-hand side. What if we flipped that and we put the calorie count on the left side? Well, what they found when they did that is the number of calories decreased 24%. And so they thought, wow, if you're thinking about the calories first and then you're thinking about that delicious cheeseburger, maybe you're gonna take a different choice. But if you're thinking about that delicious cheeseburger and then looking at the calories, your mind's already on the cheeseburger, right? It's a lost cause. So what they did is they found that, and then they did a great thing, right? They said, well, let's test this out. How else can we test it out? So they took a population of Hebrew-speaking individuals, and they found the opposite, right? When you do it with Hebrew-speaking individuals, when you put it on the right-hand side instead of the left, the conclusions were reversed. So those are the things that get us excited as behavioral scientists. We take a look, and we at the Participant Center for the All of Us Research Program, this is why I originally got hired. I had worked with Steve and Eric on a clinical trial, and we came in, we did a little bit of A/B testing, we did some message changes, and they said, hey, come do that for 1 million or more people. And I said, awesome, that's so exciting to me. It's been a challenge. So our team here has been working through 2.5 years of thinking through all the privacy concerns, thinking through what it takes to really understand behavior and test it in a robust sort of way so that we can start to learn how to communicate with people and how to disseminate that knowledge and improve the way we communicate in medical research trials and in healthcare in general. So these are just a couple of examples. We're really early in the process, but we had a great designer that works out of the NIH, Toral Contractor, take that original article back from the Wired magazine and started to think through, when we start to return information on blood assays, what might it look like? And this will be like our initial one that we start to test against. And we've started doing A/B testing and online advertising so we can start to look at what messages resonate with different communities. And it's been, lots of just, bringing the science into this part of it has been challenging, but I think it's going to be really beneficial as we start to bring things full circle. The initial thing is, as we get to individualized, personalized medicine, we also want to get there for our communication. We want to be able to reach people. We want to understand what their motivations are, what their barriers are, how they want to be engaged over time. Because each one of our participants really has a different story, a different reason for joining, a different concern. I'm going to show you a couple of these now. Michael, who still works with us, his reason might be he joined lots and lots of clinical trials, and they all failed until he has HIV, and until he reached the right one. And then he was able to still be with us today and work on the All of Us research program. We have amazing veterans who are choosing to be a part of the program to continue their contribution to the country in their service. We have people who have never been a part of clinical trials before, who don't understand what is in their background, in their genetic background, and wanting to do that for their communities and their families. We have people who really, really care about making sure that their communities are represented and given the right treatments over time. We have our communications director, who is a breast cancer survivor herself, whose mom died of breast cancer when she was 40. So it's really about, figuring out what that individual message is, what those reasons are, and testing it in a way that we can give back to our communities. I do this with a big team here at Scripps Research and a big team across the whole participant center with our sub-awardees. So we would like, on behalf of all of those folks, to invite you, if you do have a reason for joining as well, we invite you to join us as a participant, as a partner, or as a researcher over time. Thank you.
If you'd like.
For a couple of questions, if anybody has them. One or two, Ali says.
Peter Kuhn, USC. So how would disease-related programs, as opposed to the health-related program, how do you connect up? What is the mechanism? So lots of those of us who work in the disease space, cancer or otherwise, want to go down this path. The understanding that participation actually improves outcomes. We might actually be able to go to clinical utility faster.
Yes.
But ideally, right, we would connect up.
We would connect the databases? Is
Yeah,
that what you're
the
saying?
databases and the efforts, to be perfectly
Yeah.
honest, right?
Yeah.
I mean, again, right, Southern California, 20 million people,
Right.
plenty of traditionally underrepresented.
Yeah, and so we're figuring out now at the NIH leadership level of how do we start to connect all of these efforts, because we're certainly not the only one, right? There's lots of efforts going on, so how do we combine that and how do we get the right mix in that initial of a healthy cohort and a disease cohort, and how do we bring that together? And I know there's lots of talks to try and do that over time, but we can definitely follow up. Yeah, Esmeralda.
Hi, Katie.
Hi.
Thanks for the great presentation. Esmeralda Costas, NIH NCI. So there are a lot of concerns out there about returning genetic reports back to patients or participants. I was wondering if you've done any focus groups to understand whether or not the public is comfortable with that, and if there are resources that are going to be available for people who have questions about their genetic reports.
Yeah, and so lots of community-based focus groups and forums were done in the initial planning phase of the program. I think overall people are really eager to have their genetic information returned back to them. Like I said, there's lots and lots of working groups and forums now within the initiative trying to figure that out. The Genome Center grants were announced a few months ago, and there is also going to be a genetic counseling RFP that comes out very soon. So everybody will have access to a genetic counselor as a part of the program, and everybody will get their genetic results back.
Excellent. Thank you.
Thanks, Esmeralda.
Can you comment about data availability, when that will be available, who it will be available to, and then also what types of more molecular genomic assays are being done as part of this?
Yeah, so there's going to be a data browser available, I think, by the summer that has very, very limited data, but you can kind of take a look at who's in the cohort now and what sort of data we're bringing in. And then the Research Hub is supposed to be available at the end of 2019. Getting in trouble here. It's supposed to be available. I would just caution that in programs like this, the timelines tend to shift a little bit, but it should be. The assay pilot right now that's going on, and I can't remember off the top of my head what we're studying, but that's going to happen also in the summer on 5,000 individuals, and then we're going to roll it out cohort-wide.
Genetics, you mean?
The blood assays pilot,
okay.
yeah, and then the genomic pilot is going to be at the end of the summer and into the fall of 2019 as well.
And who will have access to all this data in the end?
So once we establish the Research Hub, there's tiered access, but it's not that stringent. You go through your privacy, but it's going to be available, or your privacy sort of things, but it's going to be available from anyone from citizen scientists all the way up to elite universities. So it really is meant to be an open access resource for all. I'm not sure, it kind of changes a little bit every time I see a new deck about the timelines and what that looks like, so it's still in the works, but we can keep you posted.
In terms of biospecimen repository, what kind of samples are you collecting?
We are collecting blood, 8 vials right now. We're collecting urine, and we're about to launch a salivary pilot where we're going to get salivary DNA on folks who aren't close to a brick and mortar site.
And blood includes serum or plasma?
That I don't know. I'll have to phone a friend because I'm not a medical professional, and I don't get into the weeds on those quite so much. I'm sorry. Yeah. All right. Thank you.